Growth in Medicare Advantage is easy. Converting that growth into sustainable profit is the actual challenge. Across the industry, adding new members is inherently expensive. Upfront clinical activation costs and initial diagnostic gaps mean first-year enrollees reliably drain capital. But looking at this cohort performance chart from Clover Health, we see a stark anomaly. First-year members run at a loss, losing $145 per month. Yet as those cohorts mature and return, they generate a $200 profit. This degree of margin expansion requires a mechanism far more powerful than standard insurance underwriting to execute. Most health plans attempt to neutralize their acquisition costs through aggressive coding intensity, narrow and restricted provider networks, or relying on annual rate increases. Clover does not rely on those traditional levers. They operate a wide network PPO, meaning patients retain choice, and they hold full underwriting risk rather than delegating the economics downward to the doctors. The profitability is actually driven by a proprietary software architecture embedded directly into the primary care exam room. This technology is called Counterpart Assistant. The extreme macro-level profitability curve seen on the balance sheet is simply the aggregate financial output of thousands of AI-assisted clinical micro-decisions happening at the point of care. The core problem in patient care is that medical data is hopelessly fragmented. A single patient's history is scattered across CMS claims databases, external laboratory results, pharmacy records, and siloed specialist clinical notes. Having mere access to this scattered information does not improve care if the doctor cannot synthesize it into a coherent clinical profile. To solve this, the Counterpart system leverages CMS-aligned interoperability networks. It aggregates over 100 distinct data sources in real time into a unified dataset. This real-time aggregation is the absolute mandatory prerequisite. Without it, no predictive AI or workflow intervention can be deployed with any accuracy. Health tech innovations routinely fail because they introduce workflow friction. They ask overburdened physicians to leave their primary screen and log into separate, clunky portals. Counterpart Assistant bypasses this friction entirely. It embeds directly inside the native electronic health records that doctors already use, like Epic. Once inside the workflow, the platform deploys a generative AI conversational interface to interpret the newly aggregated data. Physicians can query a patient's entire longitudinal history using natural language, pulling up direct links to source documents, all within a strictly PHI-safe environment. This eliminates the 15 minutes a doctor typically spends digging through dense charts before an appointment, replacing the manual search with instant, proactive pre-visit summaries. True workflow integration converts passive historical records into immediate, actionable intelligence at the exact moment a clinical decision is made. Supplying physicians with this immediate, synthesized intelligence produces highly measurable clinical consequences. The system generates predictive prompts that actively alter the trajectory of chronic diseases, starting with conditions like diabetes. The empirical data shows that physicians using the platform initiate diabetes treatment an average of 3 years earlier than standard medical baselines. The same pattern holds for chronic kidney disease, where the data reveals a 1.5-year acceleration in early detection and intervention. This early management cascades directly into acute care metrics, driving an 18% reduction in all-cause hospitalizations for congestive heart failure. These are specific, measurable moments where future catastrophic medical emergencies and their associated costs are avoided entirely. Every avoided hospitalization directly impacts the core financial metric of risk-bearing insurance, the medical cost ratio, or MCR. Members whose physicians actively use Counterpart Assistant demonstrate an 8% improvement in their medical cost ratio after their very first year. As the cohort matures over 4 years and clinical engagement deepens, this cost differential widens to approximately 20%, or 1,500 basis points. Because Clover retains full underwriting risk, this reduction in medical expenses is not shared downstream. It accrues entirely to their bottom line. This 20% compounding differential is the mechanical engine driving the cohort maturation curve we examined earlier, turning initial losses into deep, recurring profit. This workflow to profitability loop was empirically proven and stress-tested under full underwriting risk within Clover's own Medicare Advantage plan. Now, the company is extracting this proven software engine from its internal insurance wrapper. They are commercializing Counterpart Health as a standalone software-as-a-service product, making it available to external health networks. This shift decouples their growth from the strict geographic constraints and high capital requirements that limit traditional risk-bearing insurance. By transitioning to an asset-light model, they introduce high-margin, recurring software revenues that restructure the company's long-term valuation profile. External partners are currently deploying this platform across the country to manage their own patient populations. Market validation is visible through multi-year agreements with major regional networks, including Southern Illinois Healthcare and the Iowa Clinic. These partners adopt the platform because it allows them to naturally hit strict value-based care metrics without adding administrative burden to their physicians. The healthcare industry must move beyond theoretical paper economics and focus entirely on empirical cost management executed directly at the exam room level. Sustainable profitability is achieved only by deploying a clinical operating system that empowers physicians, allowing clinical excellence to organically drive financial margin.